And welcome to our second B-Cell Milgram Centers of Excellence meeting this year. I want to and wish you welcome for this meeting, and I would like to acknowledge that this meeting, the second meeting for this year, is under the patronage of Saudi Society for Blood Disorders, which is actually the largest and the only national hematology society under Saudi Council, as compared to other societies which are under different institutions or universities. So we are the national society, and this is our commitment to from the SSBT to continue providing you the best continuous medical education activities. And I would like to thank our unrestricted grant from our support from Janssen, the J&J Johnson Johnson company, for their continuous support for the last year and this year. And we have made a commitment that we will provide a meeting that will be free of any bias or any overdue. This is an unrestricted grant for the conduct of the meeting. The whole meeting is organized and conducted by under the SSBD, and our support has come from Jensen for their full support and logistics. And thank you very much. I would like to take this opportunity to thank Jensen for supporting this meeting. So to go over, let me introduce today's speakers. I'll be the one who will be chairing the overall meeting. I work as a consultant in hematology, stem cell transplantation, and cellular therapy in the Oncology Center at King Faisal Specialist Hospital and Research Center. And I also hold a position of Professor of College of Medicine at Al Faisal University. All three speakers today, including myself, we are primarily involved in malignant hematological disorders and specifically for chronic lymphocytic leukemia, B-cell malignancies, and lymphomas. Our first speaker I'll introduce is Dr. Feras Alfraih, who's a consultant also in hematology, stem cell transplantation, and cellular therapy. He's also the director of alternate donor stem cell transplantation program of King Faisal Specialist Hospital and Research Center, and is primarily what we call, I should say, who has developed the alternate donor registry, which is the countrywide. He's also assistant professor at College of Medicine at Al Faisal University. His primary interest also is B-cell malignancies, lymphomas, specifically chronic leukemias. Our other speaker is Dr. Riyad Al-Faqih. Also, he's a consultant in hematology, stem cell transplantation, cellular therapy. Also, he's also the acting head of a clinical research department of King Faisal Specialist Hospital. It's a new department under which all the clinical research, the trials, will go under one umbrella, which will be the clinical research department from all over the hospital. So we wish him best of luck also for assuming this position. Just recently, he was asked to head the clinical research department. He's also an associate professor, College of Medicine, Al Faisal University, and his primary interest also is, other than stem cell transplantation, is the B-cell malignancies, and he's also in the core program, like Dr. Feras and myself, in the lymphomas and chronic lymphocytic leukemias. So let me introduce the program today. After this introduction, we will go to our first speaker. This is Dr. Feras Alfraih, who will talk about risk stratification management and frontline management of chronic lymphocytic leukemia, which will be followed by a discussion in which Dr. Feras, myself, and Dr. Riyad Al-Faqih will join, and audience can put up their questions. It would be better if you put them questions in while you're listening to the talks as a chat in the chat, so we can tabulate your questions and not to repeat the same questions. So at least we know what is the crux of the questions that we need to ask the speakers. We'll go to the advanced management. I will talk about relapsed refractory CLL based on the few cases that I have. We'll again have some discussion on question and answer session again with the whole group. We will take a break at from 12:05 to 12:15 for about 10 minutes. And then we'll go to the breakout sessions where will be the case discussions by Dr. Riyad Al-Faqih, who will talk about the frontline management case discussions, and Dr. Feras will be talking about the relapse refractory setup of case discussions, and the audience will be switched. So the one who will go to the first case discussion, then after 20 minutes, will switch to the second session. And at 1 o'clock, hopefully, we'll have closed this fruitful session, inshallah. So let me introduce and invite our first speaker, Dr. Feras Alfraih. Feras, thank you. You can take over. Feras, you're still mute.
Assalamu alaikum. Good morning, everyone. So do you see my slide?
Yes, Dr. Feras.
Okay, so I'll try to go today. This is outline of my talk. It will be diagnosis, staging, and prognosis, and then we'll try to address the frontline treatment options. So starting with pathogenesis, as all of us are aware, actually, there are pathogenic events happens on the B lymphocytes, and it caused abnormality that leads to cytogenetic abnormality, then proliferation to monoclonal B lymphocytosis. Further proliferation categorize the disease to be CLL/SLL. I would like to remind you that CLL/SLL, so CLL is more than 5,000 B lymphocyte in the peripheral blood for at least 3-month duration. Less than that is called monoclonal B lymphocytosis. SLL and CLL are two sides of the same coin. Diagnosis confirmation can be done by flow cytometry. There are important immunophenotype, which are CD5 and the P markers, CD19, 20, 23, and either Kappa or Lambda. Usually these markers are more than enough. However, it's not uncommon to have non-classic flow cytometry, whether absent CD5 or any other parameters. That's why differential diagnosis of CLL is relatively wide and not uncommon that the diagnosis might be difficult sometimes. 23 and CD10 is important also to differentiate the disease from other categories. In case of borderline cases, additional immunophenotype for 43, 79, 81, 200, or ROR1 are sometimes useful. Morphology is very important. The classic feature of CLL is very helpful. And I would like to remind you that sometimes we get confused with the presence of pro-lymphocyte and whether we are dealing with CLL versus pro-lymphocytic leukemia, either it is a CLL transforming to pro-lymphocytic leukemia. So the presence of up to 55% of pro-lymphocyte is common in CLL. Switching to that staging, so CLL is very heterogeneous disease. Over the last decades, the staging underwent a lot of progress. Initially, it was a clinical features from 1980, then the addition of protein markers, followed by genetic alteration, transcriptional alteration, and epigenetic alterations. So RISE staging is one of the oldest staging from 0 to 4. It does correlate with the median survival of the patients. PNA staging is another important clinical classification. However, I would like to highlight that the hemoglobin level in PNA staging is 10 versus 11 in RISE staging. Are those good enough? Definitely no. Both are old. Both are relying mainly in clinical and some basic investigations. They are looking mainly into the overall survival. And if you look at the projected prognosis interval, it is very wide. And definitely genetic and molecular biologies were not included. So this is essential staging, which is CLL IPI. It was introduced in 2016. It incorporates age as well as clinical staging, beta-2 microglobulin, which is sometimes overlooked. IGHV becomes essential in treatment as well as in staging, and the cytogenetic for deletion 17 and P53. Overall survival in CLL patients hugely vary between 93% in the 5-year versus 23% for those with very high risk disease. Also, it does help in predicting time to first treatment. So this is some of the important prognostic markers. I would just emphasize on the cytogenetic here. Deletion 13 is a classic good prognosis, while deletion 11 and 17 are bad prognostic markers. CD38 is also sometimes used to look at the good prognosis of the patient. It is widely available. ZAP70, it's not commonly available in many centers. ZAP70 negativity is also a good prognostic. Lymphocyte doubling time is another one. So P53. P53 is very bad cytogenetic abnormality. It carries worse outcome, and this is one of the studies showing that the value in the outcome. However, I would like to highlight that the correlation between deletion 17 and P53. So a patient can be categorized into 3 categories. So you might have a patient with deletion 17 but no P53. You might have a patient with deletion 17 with P53, and sometimes you have P53 with no deletion 17. So it is important that they are not the same sides of the cytogenetic abnormalities. That's why it's important that you do both. IGHV is another important marker. Unmutated IGHV, patients do have a worse outcome. I mean, the first publication was 1990, or actually this is one of the first. It's not the first. It's more than 20 years ago. IGHV is molecular analysis. It is very well standardized by the European Center, and it has to be done only once. Keep in mind, around 50% of the CLL patients, they do have unmutated IGHV. Beta-2 microglobulin is also an important prognostic marker. More than, I mean, the level is more than 2, between 2 to 3, or more than that. Again, cytogenetic abnormalities, specifically deletion 17 and P53 and IGHV are essential nowadays. So if you look at the IWCLL guidelines for the essential tests prior to the treatment, so cytogenetic, FISH specifically is essential and can be done in peripheral blood. P53 and IGHV always shall be done. And I would like to point out that bone marrow aspirate is not an essential. It is usually practiced in clinical trials or in some selected cases. Same thing does apply for CT scans. So moving forward for the treatment, so CLL is not is treatable but not curable disease. The goal of treatment usually is to elevate symptoms, reverse cytopenia, improve quality of life, and or prolong overall survival. The disease is very dynamic. Approximately 70% of the patient will require treatment. However, 1/3 they might not require treatment. And for those who require treatment, we are divided between the need for treatment very early versus late requirement for treatment. Dynamic of disease also does vary: spontaneous regression, logistic growth, or exponential growth based on multiple factors. One of them is molecular mutations. So before starting starting treatment, so there are two questions that we have to answer. Is there an indication for treatment? In other words, is the disease active? The second is medical fitness. So not all patients require treatment. So for stage 0 RI or A BNA, usually they should not be started in treatment. BNA stage C and RI stage 3 or 4 are usually the indicated. Those in between, it has to be customized based on the patient condition and as well as patient wishes. So what's the definition of active disease? Just reminding myself as well as you that having an evidence of bone marrow failure, whether it's cytopenia, anemia, thrombocytopenia, massive organomegaly, lymph node more than 10 centimeter, or actually any symptomatic lymphadenopathy. It doesn't need to be 10 centimeter, splenomegaly more than 6 centimeter below the costal margin, extramedullary disease, and having a lymphocyte doubling time less than 6 months is usually an indication for treatment, and constitutional symptoms. So there are some criteria when it comes to constitutional symptoms. Not any B symptoms require treatment, and this is very important. So when you look at the weight loss, it has to be more than 10% in the last 6 months. The fatigue, it has to be affecting performance status significantly, and there is a temperature more than 38 for more than 2 weeks with no infection. There is a frequent question we face in the clinic. Is there any magic WBC threshold for treatment? And unfortunately, there is no cutoff. However, frequently, some expert opinion, I would call it, is that when patients having WBC more than 200, people tend to treat, but you can wait definitely if patient is doing very well. Medical fitness, the classic way is using performance status ECOG, comorbidities HCTI. CI has been also validated outside bone marrow transplant. The CCI assessment index is very famous. However, I would like to remind you that CLL is a disease of older adults. That's why a proper assessment shall be conducted. There are different ways on how to do geriatric medical fitness assessment, psychological, physical, nutritional, social support, cognitive assessment. However, I would like to emphasize that ECOG lacks sensitivity in identifying impairment in physical function in older adults. There are other assessment tools that can be used to assess the medical fitness. One of the famous one is SPPP, Short Physical Performance Battery. This is very simple, by the way. There are an application for SPPP that you can do it. It can be done within 10 minutes. So ECOG is not sensitive to differentiate patients with subclinical vulnerability from those who are fit. Cognitive function with a 3MS is very important also. So moving toward the last part, which will be a first-line treatment option. We'll go over some important studies. For example, CLL 8 looked at the FCR versus FC in younger fit patient, and it showed clearly that FCR was superior. It was very long median follow-up. Then CLL 10 looked at FCR versus bendamustine, and again, in a fit patient, FCR was superior. ECOG 1912 looked at FCR versus protonibrotuximab in less than 70 fit patient, and actually did show superiority. specifically mainly for the progression-free survival. However, the overall survival advantage was less than PFS. If you look at the subgroup of patients without the gender, the age, lymphadenopathy, organomegaly, IgHV, it actually was effective across all patients. However, it's important to highlight that the efficacy into the IgHV. So the efficacy in unmutated IgHV of the use of ibrutinib was very prominent versus mutated IgHV. So ibrutinib versus FCR were almost equivocal when it comes for mutated IgHV young fit patient. Response rate overall was in favor of ibrutinib rituximab. When we look at the safety, so grade 3 toxicity, 3 to 4, and the FCR were 72 versus 58 for ibrutinib, neutropenia 44 versus 23, as well as infectious complications. It's important to highlight some of important side effects of ibrutinib. So neutropenia, grade 4 is around 14%. Atrial fibrillation, it happens of 3 and 4, grade 3 and 4 around 3%. Hypertension, which is an important side effect, 20%. Interestingly, the hypertension side effect in ibrutinib increases over the time, while the incidence of other side effects usually decreases with the time. Can IgHV be used as a predictive factor in clinical practice? Definitely. And so when it looks at the outcome of P53 patients, whether they are treatment naive or relapse refractory, definitely the outcome is poor, and currently there is no place for chemoimmunotherapy when you have a patient with P53 abnormality. CLL 11 looked at the impact in older adults and looked at rituximab chlorambucil versus chlorambucil obinutuzumab, and the addition of obinutuzumab was superior when it comes to the progression PFS, while it was not, there was no impact on overall survival. Alliance study is another important study, looked into naive older adults. That was ibrutinib plus minus rituximab versus bendamustine, and ibrutinib was superior than bendamustine when it comes in the older adult. However, the addition of rituximab did not reflect a superior advantage. So one of the advantages of ibrutinib is long-term follow-up. We already covered the side effects. So CLL 14 is venetoclax and obinutuzumab, and also it did show venetoclax is superior than chlorambucil obinutuzumab. Venetoclax is very safe treatment. However, there are some important side effects which are relatively very rare, including gastrointestinal, which was 8% versus 3.3 in the control arm. Captivate study is looking at the in the first line, looking at the combination of ibrutinib plus venetoclax. And it did show significant improvement in the outcome. And there was significant response. Advantage of venetoclax is the negative MRD. There was a higher MRD negativity in when we are combining the two agents. Okay. Lastly, so response to treatment. So this is very important. We know how to assess or how what tests shall be done at the beginning of treatment. So after finishing the treatment, how to assess. So I would like again that to emphasize bone marrow is not indicated except in special conditions. For example, when there is a cytopenia, or when you want to assess for MRD. History, physical exam, CBC, differential, as well as peripheral blood morphology is more than enough in assessing response to treatment as per IWCLL diagnostic recommendation. When we have a patient, it's very important to understand the response to treatment, whether it is CR, partial response, progressive disease, or stable disease. So in CR, there should be no lymph node more than 1.5, and spleen size should be less than 13. So basically, there is no evidence of disease. In partial response, that having two, one from group A, one from group B is enough. If you have if the decrease in the lymphocyte size is less than 50%, then this might be qualifying for progressive disease, increasing lymphocyte count, and then the last is stable disease. So in summary, that CR, all criteria has to be met. Stable disease, all criteria has to be met. PR and PD, you have to look into it carefully. So in summary, how to treat a patient at frontline, a treatment naive. So there are important factors that has to be taken on. Clinical situation, now we say that treatment naive, P53, IGHV, we have looked at comorbidities as well as the age. So in absence of P53 mutation and mutated IGHV, so the options are FCR, bendamustine, venetoclax, obinutuzumab are option. However, if you have presence of P53, everything is irrelevant. So there is no rule for chemotherapy. So it has to be either ibrutinib, venetoclax, obinutuzumab, or idalasisib or rituximab. This is my last slide, and thank you. Be happy to take questions.
Thank you very much, Feras, for a wonderful talk. We have a few questions. If you put the time in the program slide, we have one question for sure. I'm sure there'll be more questions as the time passes by. They're asking, there's one question, they said that if somebody is a 40-year-old gentleman and they don't have the testing abilities in their institution for IGHV or other molecular testing, I think they should asking for P53. If there's none is available, it's a young patient who requires therapy. What would be your choice for the first-line treatment in the absence of these? Because these things are not available. So what would be your choice or recommendation for that center?
This is a very good question, and it's a practical question. IGHV tests, for example, or actually the proper cytogenetic are not available everywhere. So number one, I would like to remind that these are essential tests, and hopefully will be more available in the country. Second option is, what shall you do? Shall you under-treat the patient or over-treat the patient? By saying under-treat, by assuming that he's mutated IGHV, for example, and then by giving him a chemotherapy with FCR, or you will over-treat by giving him ibrutinib, or venetoclax. I would be more inclined to over-treat, especially in young patients, rather than under-treat. So If the test is not available, I would assume the worst, and I will treat accordingly with targeted agents.
Okay. So meaning that means you'll encourage them first to get these tests done or refer the patient. But if there's no choice, then for a young patient, rather overtreat rather than undertreat. Okay, that's good. I think somebody may be writing question. Then let me ask you a question now. For these upfront therapies, do you think for the monoclonal antibody use, for example, for rituximab or obinutuzumab, do you have any choice? Would you consider switching to obinutuzumab, or you think that rituximab in combination for somebody who's a mutated and you want to use FCR or bendamustine? Would you?
So there are studies actually. Obinutuzumab is very potent anti-CD20 and it is superior. The problem with obinutuzumab is the cost. I mean, it is very expensive medication, and at least in King Faisal Riyadh, this medication is not available. I don't know about other centers.
Okay. Any other comment from anybody else in the group? Riyadh, do you have any question?
No, I mean,
or any comment on the questions that have been asked so far?
So for the question of the 40-year-old, you have to do your best guess and treat. Now, chemotherapy for unmutated does work, but not as good as for mutated. We know that, okay? If the patient was mutated and you give them FCR, they have a 60% chance to be disease-free at 10, 12 years. Okay, we know that now. So maybe with a 6 month of therapy, the patient will end up for 10, 12 years without any additional therapy. So cost effective and easy on the patient. But if we don't know whether he's mutated or unmutated, both choices, I mean, ibrutinib versus or targeted therapy versus chemo are valid. We know that chemo does not work as well as in the mutated, but it does work. It's not like absolute to give targeted therapies for the unmutated. It is associated with a better outcome, but it's still an option. Here it comes to physician preference, and me myself, I prefer 6 months of therapy versus putting the patient on something continuous. So limited therapy if I don't know, and then upon relapse, I still have these agents available. This is personal preference. This is not backed up by data.
And hopefully, I mean, I think most of the centers will have these things available soon if they're not available right now. So the choice would be easier. Okay, well, both points well taken. I think what we can do is, if there is no further question, we can move to our next talk. It's almost time to go to the next talk for advances in management of relapsed and refractory CLL.